Dr Paul Monaghan.
Thank you, Mr Rosendahl, for the opportunity to consider today the important issue of suicide, particularly male suicide, and to represent the Scottish National Party in this debate. I congratulate the honourable member for winning this important debate, but I must admit that I found many of his remarks unrelated to the title of the debate. I am certain, Mr Chairman, that the lives of all of us in the room today, men and women, will have been touched by suicide in our families, among our circle of friends, or perhaps in our wider social network. That's certainly the case for me. The reasons that people are driven to take their life are, of course, both complex and intensely personal. However, depression, alcohol and drug misuse, unemployment, family and relationship problems, including divorce, social isolation, wealth inequality, social disadvantage and low self-esteem are identified as key triggers for male suicide. Sadly, those with severe mental illness remain at the highest risk of suicide, and among them, those who refuse or those who decline medical treatment are at a higher risk still, and particularly vulnerable. In addition to health issues, social and economic factors influence people to take their life. I've alluded to wealth inequality already, but we know that men in midlife from low-income backgrounds are consistently identified as the highest risk group. In England, Northern Ireland and Scotland, the male suicide rate is approximately 3.5 times higher than the comparative female rate. In Wales, the male suicide rate is approximately 4.5 times higher than the female rate. In September 2012, the UK Government published a report entitled Suicide Prevention Strategy for England. That report identified factors influencing increases in suicide rates in England. The report was clear in noting that periods of unemployment and severe economic problems do adversely affect the mental health of the population and can be associated with higher rates of suicide. The report was followed up in 2014. In that year, last year, the study again found an association between the areas of England worst affected by unemployment and increased prevalence of suicide. Indeed, between 2008 and 2010, there were approximately 800 more suicides among men and 155 more among women than might have been expected based on analysis of historical trends. Like me, my colleagues in the Scottish Government are deeply concerned with suicide rates also, and have put in place a suicide prevention strategy that clearly sets out the actions the Scottish Government is taking to prevent and further reduce suicide in Scotland. The statistics on Scotland on suicide, which currently indicate a downward trend, even in male suicide rates, show that the Scottish Government strategy is achieving outcomes that run counter to the general trend for the UK. The Scottish Government's strategy has 5 key themes. The first is responding to people in distress. Second, talking about suicide. Improving NHS Scotland's response to suicide. Further developing the evidence base. And lastly, supporting a broad programme of change and improvement. In developing these themes, the Scottish Government has acknowledged that there is a broader focus of activities that can effectively contribute to reducing overall rates of suicide. Activities within this broader focus of activity include building personal resilience and promoting mental and emotional well-being in both schools and in the general population, working to reduce inequality, discrimination and stigma, promoting high-quality early years services and working to eradicate poverty. All of this work is undertaken in a context of enhanced vigilance in respect of improving mental health, supporting people who experience mental illness and, of course, preventing suicide. The Scottish Government's original suicide prevention target was to reduce the suicide rate in Scotland by 20% by 2013. Since 2002, when that target was originally set as part of the Choose Life strategy and action plan, we have seen an 18% reduction in the suicide rate. In the years 2009 to 2012, Scotland has seen the lowest number of suicides since the early 1990s. That is a reduction in the number of suicides at a time when many other jurisdictions were mapping increases. Nevertheless, there are some comparable trends with the UK. Taking probable suicide figures for 2011 and 2012 together, almost 3/4 of those who died in Scotland were male. This gender imbalance has been broadly consistent for much of the last 10 years. However, the major element of the 18% reduction in the suicide rate since 2000 has been a reduction in male suicides. The Scottish Government's suicide prevention strategy now establishes a revised target to reduce the suicide rate in Scotland by a further 10% by 2020. This target mirrors the global target established by the World Health Organization. The Scottish Government's strategy focuses on suicide prevention activities in communities and in public services to enable people to live longer, healthier lives, which is a national outcome. The strategy makes manifest a determined commitment of the government of my country to continue the downward trend in the rate of suicide and to make progress towards meeting the WHO target. Mr Rosendale, International Men's Day focuses on life issues, including suicide rate, violence against men and boys, educating and parenting. International Men's Day has stated, when 13 men a day in the UK are dying from suicide, it is essential that everyone in positions of power, trust and influence do everything that they can to help men talk about the issues that affect them. International Men's Day supports the campaign for improved outcomes led by the Campaign Against Living Miserably, which also seeks to raise awareness of male suicide. The campaign aims to encourage people to talk about male suicide in the hope that this will decrease the number of male deaths attributable to suicide across the UK. To the campaign's great credit, the organisation's helpline currently receives over 5,000 calls per month from individuals seeking advice and support. 80% of calls to this helpline are from men. The Campaign Against Living Miserably has stated, "It is our belief that all of us at one time or another, regardless of gender, will hit a crisis and we could all do with specialist help when things go wrong." These are wise words. The Campaign Against Living Miserably has also released a parliamentary briefing that highlights an adverse impact of the UK Government's work capability assessments on suicide rates and notes that each suicide costs an estimated £1.7 million, in addition, of course, to the much more significant and obvious catastrophic emotional and social impact of a life being lost. I noted recently that the Journal of Epidemiology and Community Health found that suicide was associated with the UK Government's Work Capability Assessment Programme. Indeed, the research found that each additional 10,000 people subjected to work-capable assessments was associated with an additional 6 suicides, 2,700 cases of reported mental health problems, and an additional 7,020 prescriptions for antidepressants. In sum, that adds up to an additional 590 suicides, 279,000 cases of mental health problems, and 725,000 additional prescriptions of antidepressants based on current claim levels. These figures are for England alone. The researchers noted, our study provides evidence that the policy in England of reassessing the eligibility of benefit recipients using the work capability assessment may have unintended consequences for population mental health. 590 suicides at £1.7 million sums to over £1 billion. We must, of course, add to that figure the cost of treating and supporting almost 300,000 people struggling with mental health problems, and count the cost of providing almost 750,000 prescriptions for antidepressants. Again, these figures are for England alone. Significant as the financial costs are, they fade into insignificance when compared with the human cost of lives lost opportunity wasted and families destroyed by suicide. It seems clear, therefore, that in addition to health, economic and social status, UK government policy is directly contributing to the prevalence of suicide today and imposing enormous financial pressures on public services already struggling to cope with significant budget cuts. Work capability assessments and the work programme are having a significant negative effect on mental health. Reports repeatedly highlight the heart sink felt by people when they receive a request from authorities to apply for jobs they are unlikely to win and hear nothing back, and of the stressful targets enforced by job centres contributing to a lack of self-worth. Work capability assessments exacerbate feelings of failure and are increasingly being cited as significant factors in individuals' decisions to attempt suicide. When individuals are already vulnerable and already likely to be suffering with low self-esteem and experiencing chronic stress in respect of providing for their families, work capability assessments contribute nothing positive. It's clear that more men take their own life than women. Nevertheless, the effects of austerity and its mental health impacts are felt just as strongly by women and indeed by those left behind in society. I suggest that the Minister take up the challenges of tackling the socioeconomic inequalities in society and recognise that social exclusion is a very significant risk indicator of suicide. I would like the UK Government to pay attention to the needs of boys, teenagers and young men to prevent vulnerability in later years and perhaps more straightforwardly scrap the work capability assessment that is proving to be far too costly in terms of both human life and finance wasted. Suicide, Mr Rosendale, must not be thought of as an issue that is solely affecting men just because the number of deaths is higher among men. Any campaign targeting suicide must be focused on the entire population.